Well, thank you, Matteo. I'd like to thank you, and I'd like to thank, Professor Ramadori and all of Hepatoma team for inviting me today. So I'm going to get us kicked off today, focusing on intrahepatic cholangiocarcinoma, a disease that's been kind of near and dear to my heart for the past 15 to 20 years, and talk about some of the lessons learned through some of the work we've done through our international consortium and collaboration and collecting data from throughout the world on this disease. As you can see here, we've put together an international consortium that spans, I believe, every continent except Antarctica. And over the past 15 or 20 years, we've been able to amass data on patients with intrahepatic cholangiocarcinoma that approaches about 2,000 patients with this disease. So as most of you know, intrahepatic cholangiocarcinoma is increasing in incidence worldwide. Many patients will present like this with an asymptomatic mass in their liver. And when they do, frequently this mass will be biopsied. What the pathologist looks for when examining this biopsy is for evidence of dysplasia and also performing an immunohistochemical stain to rule out possible other primary adenocarcinomas such as lung, colon, or pancreas. So you'll see a negative IHC panel for these markers, and then a positive panel for things that would be suggestive of biliary epithelium. And frequently it'll come back with a diagnosis of adenocarcinoma, highly suspicious of a hepatopancreaticobiliary primary. When working these patients up, it's important to know that intrahepatic cholangiocarcinoma has 3 different morphologic subtypes. There's the mass-forming subtype, which you can see here in panel A. These lesions tend to be low attenuating lesions, and if by the capsule, you'll see capsular retraction with some rim enhancement. There's also the periductal infiltrating intrahepatic cholangiocarcinoma, and these tumors usually present with periductal enhancement and periductal thickening with some irregularly dilated intrahepatic ducts. And then there's also the interductal growth pattern, which usually presents as this ductatasia, this kind of sausage-like appearance of the biliary tree, and you may or may not see a intraductal papillary mass. In general, the most common type of intrahepatic cholangiocarcinoma, if you look at our large international series, is the mass-forming lesion. And on CT, this mass-forming lesion will present very different than a hepatocellular carcinoma, whereas hepatocellular carcinomas tend to have early enhancement and late washout. These intrahepatic lesions, intrahepatic cholangiocarcinoma lesions tend to be more fibrinous with a dense stroma, and therefore on the early phases of the images, they tend to be more hypointense, and only later phases do they tend to be arterially enhancing. Another kind of sine qua non of these lesions is this peritumoral ductal dilatation. We tend to use a lot of MRI here at Ohio State. This would be a classic appearance of an intrahepatic cholangiocarcinoma. You can see in panel A, a very hypointense lesion with some capsular retraction. On panel B, later phases of the MRI, you can see that it starts to enhance and has central necrosis. And then in panel C, you can see that periductal dilatation that I was speaking about earlier on. I tend to use a fair amount of PET for these patients because the intrahepatic cholangiocarcinoma is very PET FDG avid. And in about 20 to 30% of patients, the PET will change your therapeutic approach. It may identify otherwise occult metastatic disease. In some patients, it may even identify a previously unanticipated primary tumor from the stomach or the colon. And then, at least in my practice, if patients have FDG avid nodal disease in station 12 and the hepatoduodenal ligament, or especially outside of station 12, then I'm likely to treat those patients with preoperative chemotherapy prior to taking them to the operating room. Why is that the case? Well, frequently these patients present with very large tumors. Many patients present with asymptomatic or vague symptoms, and therefore the tumors have an opportunity to really progress before they're discovered. Here is a patient of mine who has a very large central tumor that's occluded the right anterior portal vein and is abutting the right posterior sectoral branch and is involving the right hemiliver as well as segment 4. And this patient needed an extended right hemihepatectomy. And you can see here the base of the umbilical fissure. And here on the ex vivo specimen, you can see all of the right liver, the gallbladder in situ, and then this large mass. You can see that these tumors can be very challenging to operate on. Here's a different patient with a large tumor in the left hemiliver with no visualization of the middle or left hepatic vein. This patient had a very large tumor and a modestly elevated CA19-9. And you can see here on the coronal cuts that involves most of the left hemiliver. This patient was treated with preoperative chemotherapy and then taken to the operating room for an extended left hemihepatectomy and is alive about 2 years later, disease-free. This is a different patient with a very large tumor in the right hemiliver who has some ascites, also had biliary obstruction. You can see a plastic stent in place and had a CA19-9 that was over 100,000. This patient got extensive preoperative chemotherapy, had resolution of their ascites, and had a good response to their CA19-9, coming down to less than 5,000, although not complete resolution. This patient underwent a right hemihepatectomy, but quickly recurred within 6 months and subsequently died. So I think these two cases exemplify how these are big operations in complex clinical situations, and some patients may benefit from surgery and have long-term survival, whereas other patients can recur extremely quickly. One thing that surgeons need to think about is what type of operation to perform at the time of surgery. There's been lots of discussions around anatomic versus non-anatomic resections for hepatocellular carcinoma, because we believe the cancer tracks along the portal triads. When looking at our data from our consortium, there appears to be no benefit to whether the surgeon performs an anatomic versus non-anatomic resection. And what really matters, perhaps not surprisingly, is the simple obtaining of a margin negative resection. And these data would suggest that if one can achieve a margin of 10 millimeters or more, that it has both an overall and disease-free survival benefit. So in general, when approaching these tumors, one needs to be concerned less about whether you perform a true anatomic dissection and be concerned more about ensuring that you achieve a margin negative resection. Well, up until the 6th edition of the AJCC staging manual, there was no staging for intrahepatic cholangiocarcinoma in the postoperative setting. And if you looked, intrahepatic cholangiocarcinoma was staged exactly the same as hepatocellular carcinoma, which included an introduction of a new intrahepatic cholangiocarcinoma staging system. And then more recently, this staging system has been revised. So what you see here on this screen should really be considered the worldwide standard by which intrahepatic cholangiocarcinoma is staged in the postoperative period based on pathology. And as you can see here, T1 disease is categorized as disease that either is less than or greater than 5 centimeters, where T2 disease is in the setting of either vascular invasion or multifocal disease. And this staging system has been validated by our group as well as others, and again, should really be the standard for staging people in the postoperative period based on pathology. More recently, however, our group and others have been interested in trying to assess overall tumor burden, not only based on the pathologic specimen, but also preoperatively to help risk stratify patients with regards to long-term prognosis. And using the Pythagorean theorem, we have proposed a simple composite score of one number to assess the overall burden of disease in the liver that assesses not only the overall number of tumors, but also the size of those tumors. And perhaps not surprisingly, those patients who have low tumor burden tend to do best with a 5-year survival of 50%. And perhaps even more interestingly, those patients with a high tumor burden have a 5-year survival of only about 15% and a disease-free survival of only about 7%. So these data are helpful, I believe, because at least in our practice, those patients who present with a large tumor burden in the preoperative period perhaps should not be taken directly to surgery, but rather should receive systemic chemotherapy because we know their overall tumor biology is quite poor. Another thing that our consortium has looked at is using machine learning or artificial intelligence to come up with different phenotypic types of intrahepatic cholangiocarcinoma. And using machine learning, we identified 3 different clusters of patients, as you can see here on the panel on the left. And these patients were clustered into common intrahepatic cholangiocarcinoma, proliferative type of intrahepatic cholangiocarcinoma, and inflammatory type of intrahepatic cholangiocarcinoma based on size, CO19-9, and lymphocyte to neutrophil ratio. And again, what you can see is that those patients with an inflammatory type of intrahepatic cholangiocarcinoma did significantly worse, again suggesting that perhaps this subset of patients should be treated with preoperative chemotherapy rather than upfront surgery. Well, we've been talking pretty much consistently about the primary morphologic features of the tumor, but what about the nodal status of patients? We know from data from our group that roughly 55 or half of patients undergo a lymphadenectomy at the time of surgery. And among those patients who undergo a lymphadenectomy, the overall incidence of N1 disease is about 30%. And even if you consider those patients who did not undergo a lymphadenectomy to be N0, the incidence is still about 20%. So overall, the underlying incidence of nodal disease is somewhere in the range of 20 to 30%. And trying to use preoperative factors such as imaging, CA19-9 has proven to be pretty weak in our ability to assess whether someone has lymph node metastases or not. And therefore, we recommend that every patient undergo routine lymphadenectomy for intrahepatic cholangiocarcinoma. Because similar to pancreatic cancer and colon cancer, understanding the lymph node status of patients is critically important to their overall prognosis. And in fact, for those patients who have N1 disease, what's really driving their survival is the fact that they have nodal metastases, not their T category characteristics such as vascular invasion or unifocal or multifocal disease. When performing a lymphadenectomy, however, it is important for the surgeon to understand that there is some laterality to how the lymphatic system drains in the liver. And we routinely should harvest nodes from station 12. But if the lesion is in the left hemiliver, one should also harvest stations 1 and 3, compared to when the lesion is in the right liver, when one should harvest station 13. And our group has again shown that not only does the presence of lymph nodes matter, but also the location of the lymph nodes matter. And in fact, those patients who have lymph node metastases beyond the hepatoduodenal ligament, beyond station 12, do significantly worse, as these likely represent second echelon lymph nodes. So currently, the AJCC manual recommends that 6 lymph nodes be evaluated at the time of surgery. Unfortunately, if you look at population-based data, only about 50% of patients have at least 1 lymph node evaluated, and only about 15% of all patients have the requisite 6 lymph nodes evaluated as recommended by the staging manual. Now, after surgery, outcomes are poor. If you look here, the overall probability of cure is only about 10%, and the overall survival at 5 years is only in the range of about 30%, which is actually not too dissimilar to pancreatic cancer after a Whipple operation. And the reason for these poor outcomes is that patients recur, they recur early, and they recur in an extrahepatic site in up to 50% of individuals. suggesting that in many patients, this disease is systemic at the time of presentation. And in fact, in this paper that we recently published in JAMA Surgery, we noted that 1 in 5 patients experience a very early recurrence and recur within 6 months of surgery. So we're talking about large operations that have some level of morbidity, and 1 in 5 patients are recurring within 6 months. So that is why, again, if we could use calculators such as the one shown here to identify those patients at highest risk for very early recurrence, perhaps we should not be treating those patients with upfront surgery and should be treating those patients with preoperative chemotherapy. And again, if you look at patients with multiple tumors or lymph node metastases, many of those patients will recur. And that's why any individual who presents with multifocal disease or evidence of lymph node metastasis preoperatively, at least in my hands, will be treated with preoperative chemotherapy. And when they are treated with chemotherapy, typically that involves gem-cis. These are data from the ABC trial that demonstrated that doublet therapy with gem-cis was more effective than monotherapy with gemcitabine. And there have been several adjuvant study trials for biliary tract cancers, in particular the Protege 12 trial and the BILCAP trial. The BILCAP trial, which involved only about 20% of patients with intrahepatic cholangiocarcinoma, was deemed to be a positive trial and showed a benefit for adjuvant capecitabine for patients with resected biliary tract cancers. And now most patients are treated in the adjuvant setting with capecitabine, especially those with nodal disease. However, this therapy is still relatively ineffective or modestly effective at best. And the future really is in targeted therapy for this disease. Many patients with intrahepatic cholangiocarcinoma will have a specific molecular perturbation, either an FGFR, IDH, or a subset with BRAF. And more recently, there have been several studies looking at targeted therapy. For example, with FGFR, there may be point mutations, there may be fusions, or there may be small deletions. And in the FIGHT 202 trial, they looked at patients who either had FGFR fusions, genetic alterations, or no fusions or no alterations, and showed that with FGFR targeted therapy, those patients with fusions had an improved progression-free survival as well as overall survival. And therefore, currently the FDA in the United States has approved several FGFR targeted therapies as second-line therapy for those patients with FGFR fusions. About 15 to 20% of patients will also have an IDH alteration, and there has been prospective data and studies looking at icabinib versus placebo as second-line therapy for patients with IDH mutations. And these data have shown a overall progression-free survival benefit with IDH targeted therapy for those individuals with mutations. And then with regards to BRAF therapy, this basket trial of many different types of cancers among patients who had BRAF mutations, there was a benefit with targeted BRAF therapy in a subset of patients. And then finally, looking at immunotherapy, only about 5 to 10% of patients with cholangiocarcinoma will have a response to immunotherapy. And really where this field is heading is more combining immunotherapy with traditional cytotoxic chemotherapy. And recently at ASCO last year, there was a trial that presented gem-cis plus durvalumab versus gem-cis alone and showed a modest benefit with regards to overall survival with the 20% risk reduction relative to death. So I think some take-home points with regards to the future of intrahepatic cholangiocarcinoma is that molecular testing is essential. It should always include RNA-seq-based testing because we need to look for fusions and not simply just mutations, because as I noted with FGFR, the benefit is for those patients who have fusions rather than deletions or mutations, and therefore we should still be focused on tissue-based testing. So again, I want to thank Professor Donodan and Ramadori for the opportunity this morning. Hopefully what I've shared with you and been able to show you is that over the last 10 to 20 years working with our consortium, we've demonstrated that intrahepatic cholangiocarcinoma has significantly increased in incidence, and that it is a tumor with a grave prognosis, despite even curative intent, margin negative resections, and that really what we are going to need is a more multimodality, multidisciplinary approach that's going to involve precision medicine, targeted therapy, and ongoing molecular studies of these patients, which ultimately will require more collaboration amongst many centers in order to amass the data needed to answer important questions for patients who suffer from this disease. So with that, I'll conclude, and I'll be happy to answer any questions. Thank you very much.
Thank you. Thank you very much, Tim, for this brilliant and super interesting presentation. Thank you to be today with us. I will start with a question, if I can. Can you tell us what is your opinion in terms of chemotherapy? Do you have any experience of administration of chemotherapy as a neoadjuvant chemotherapy for those patients with borderline resectable disease? I know that there is no standard for neoadjuvant chemotherapy in intrahepatic cholangio, but for instance, for those patients with lymph nodes metastasis or multifocal disease, what's your idea about that?
Yeah, thank you. So yes, I mean, as I highlighted in one of those cases, if patients have multifocal disease or if they have extrahepatic disease like lymph node disease, then we will treat them with systemic chemotherapy, GEM-CIS, and then we will also always molecularly profile these patients and perhaps treat them with targeted therapy also. I think that for patients, I want to show you this slide, for patients who have intrahepatic disease that is borderline in nature, another option is hepatic artery infusion therapy. The Memorial Sloan Kettering Group and others have shown that placing a pump can be very effective for controlling disease in the liver. And there's about 10 to 15% of patients who will have a response and be converted to having operable disease. So I think that's another approach that we will frequently use if the disease is predominantly intrahepatic.
Thank you. Thank you, Tim.
Short question. Tim, thank you very much for sharing with us your enormous experience. The cases you showed were quite advanced tumors. There are cirrhotic patients. ICC is similar to HCC. It comes in cirrhotic livers, or there is any difference in this from this point of view?
So ICCs can arise in cirrhotic livers. What we have found is that it's mostly in steatotic livers, NASH, NAFL. With the epidemic of obesity, I didn't show you, but we also have another study that has shown that steatosis is a significant risk factor for intrahepatic cholangiocarcinoma. And one does not need to go from having a steatotic liver to having a fibrotic liver to a cirrhotic liver to get intrahepatic cholangiocarcinoma. My typical patient is a woman, in her 50s or 60s who has a high BMI, a steatotic liver, and has an intrahepatic cholangiocarcinoma.
Thank you.
Any other questions? Okay, if not, Matteo,
okay.
thank you very much.
Thank you, Tim, for being with us today. Thank you very much.
You bet. Good to see everybody.
See you soon.
Bye-bye.